Hey everybody, welcome to PermanenteDocs Chat. I'm your host, Alex McDonald. I practice family and sports medicine here in Fontana, California as partner of the Southern California Permanente Medical Group. Thank you all for tuning in today from wherever you may be watching, listening, or if you're listening to this on demand later. Please be sure to check out and share our current and all of our past chats on the Permanente Medicine YouTube page. Just search Permanente Medicine YouTube and you'll find us, as well as the podcast, and a lot of great content there as well too. So I am excited to welcome back to the chat Dr. Matt Daley, a pediatrician from the Colorado Permanente Medical Group. He's been here multiple times, and either he's a glutton for punishment or he just keeps saying yes. I don't know what the answer is, but he's back again. So thank you so much, Dr. Daley, for joining us. He is an amazing vaccine researcher, as well as a member of the Advisory Committee on Immunization Practices, which provides guidance to the CDC. So this should be a great topic of discussion today. If you have questions, drop them in the chat, post them on the Facebook page, and we will try to get to as many of your questions as we can. So we're just going to jump right in here. So Dr. Daley, thank you for joining us, and tell us real quick kind of who you are and what you do.
Well, thanks so much. So I'm a practicing pediatrician at Kaiser Permanente, Colorado. And then, as you mentioned, I also do some vaccine-related work, and that includes vaccine safety research, and then also that role providing some advice to the CDCs about vaccine policy.
Fantastic. And I know when we had done some discussion ahead of time, you mentioned you're not an epidemiologist, and a lot of the questions I have are a little bit more in that vein. So if I ask something that you don't know, feel free just to tell me to go find someone else to ask. But I think your insights are really, really valuable here. So I'm excited. Well, let's jump in. So we've been hearing a lot about this threat of a tripledemic this winter, RSV, COVID, and influenza. So tell us kind of what you make of that, and if you're worried about the messaging and the language around this, and if this is a real thing we should all be concerned about.
Yeah, thanks, Alex, for that. I mean, I think on the one hand, sometimes the public health messages are kind of a little bit like the sky is falling kind of a message. And I think we've all got a lot of pandemic fatigue, right? And so we hear about the tripledemic and people may think, oh my gosh, what next? What now? But in fact, as you said, it seems like these three respiratory viruses may be circulating together this winter. And even though I don't think we want a sky is falling kind of a message, I think it's real. And by real, I mean, I think we're going to see a bunch of sick children and sick adults from all three of those viral respiratory infections, which tend to be worse in the winter.
Right, exactly. Everyone's got their windows closed and cooped up inside when it's cold as well too. A lot of my pediatric colleagues here, who particularly those who work in the hospital, have seen unprecedented RSV this early in the season. And it's really straining the pediatric hospital system right now. I know there's no pediatric hospital beds available in my area right now. Can you tell us what may be causing this and what we can do to protect some of our youngest patients?
Yep, of course. So RSV is respiratory syncytial virus. And the thing is that for a lot of adults, they've never even heard of it, right? But a couple things I want to mention. One is it actually does cause a fair bit of disease in adults, maybe 6,000 to 10,000 deaths a year in adults. It tends to be the elderly and adults with chronic lung and heart problems. But I'm really familiar with it as a pediatrician because I've been seeing RSV since the first day I walked into the hospital. We see it every year. But we do think this year is looking a little bit worse, or maybe a lot worse, which I hope not. Mm-hmm. And I think it's because we didn't have RSV last year or the year before. We saw, because of the social distancing with the pandemic, we didn't see a lot of RSV last year and the year before. I've gotten a call from the hospital every couple of days that a patient of mine's been admitted to the hospital with RSV. And in October, November, that used to never happen. And mm-hmm. I actually got a call about a patient of mine who was admitted. And then 3 or 4 days later, her sister, who was 3, was admitted. And I was like, that's crazy. And I feel terrible for that family. But then I realized that 3-year-old had actually been home for 2.5 years because of the pandemic and had never gotten RSV as an infant. And so then she now got RSV. So in one family, again, their toddler and then their sort of pre-kindergarten kid or 3-year-old was admitted. So I think we're seeing unprecedented spikes in RSV, and that's actually true nationally too. We're seeing RSV in infants. Yep.
Can you talk a little bit about that more with sort of the thought of this sort of immunity gap, if you will, or sort of immunity debt, which, by the way, immunity debt is not a real thing. Can you comment a little bit about that? Do you have any thoughts there? We've been seeing a lot of messaging misinformation swirling around those two topics, and there's a little bit of a difference, and I want to kind of set the record straight there.
Right. Yeah. So I think the pandemic's taught us a lot, and it has taught us a little bit about how respiratory viruses circulate. And in the past, we've known that sometimes there are certain viruses that are bad one year, not so bad the next, bad one year, not so bad the next. And I'm not sure that we really understood why that was, but that was a pattern that we would see. And then all the patterns were thrown out the window with the pandemic and with all the social distancing. Those kids are at home with their parents. They're not in daycare, maybe. The parents are home. They're not in school. So I do think that for me, probably exposure to flu last year gives me a little protection this year. Exposure to RSV last year maybe gives me a little protection this year. But for all these kids who never got exposed to influenza or RSV last year or the year before, for good reason, because they were doing what we recommended because of the pandemic, then they probably have less immunity to influenza or RSV entering the winter than they would have otherwise. And that probably explains at least part of what we're seeing now. I don't think it's the whole answer, but it's at least part of the answer. Yep.
Yeah. And I think that goes to the point that a lot of these kind of low tech social distancing, masking, that works when it comes to helping reduce the spread of viruses in the community as well, too. So I think it's certainly interesting to see how this will play out this year, too.
I just to jump in, I certainly think it does, because there was a time in the middle of 2020 where I saw no ear infections, no pneumonias, no kids with colds, no kids with coughs. I saw some other things, kids falling off their tramp at home, but I wasn't seeing those infectious diseases that I see day in and day out as a pediatrician. And now I'm seeing them in spades.
Yeah. Same here in my family medicine clinic as well, too. Well, we're also seeing really high rates of flu already this time of year, which is, again, a little bit abnormal as well, too. What does this indicate for the flu season this year? And, added demand on the healthcare and hospitals with RSV and flu. I know a lot of our data comes from looking at the Southern Hemisphere, which is now just finishing up their flu season. What do you see coming this year for the influenza?
Right. So, one thing I'll mention is that for a lot of these respiratory viruses, they can be at their worst in the very young and the very old. Mm-hmm. And then in between, it's adults with immune compromise and chronic conditions. And so that's really true for a lot of things. And it's likely to be true for RSV, flu, and COVID. Okay, so remember in our friends and family who's most at risk. And then what do we expect from the flu this year? I think we do anticipate a worse flu season. We're seeing these early spikes. And what I don't know, and I don't know that anybody knows, is are we going to get an early spike and then it's going to kind of drop off and kind of just tail off through the winter, and maybe the winter won't be terrible? Or if we get a high spike, is it going to stay high for a long time? As I'm demonstrating with my hands, I hope you don't mind. But, with an early season, sometimes we get through the worst of the pain and then it's not so bad later, but it's so early that I think that's a little bit wishful thinking. And again, I don't want a sky is falling message, but I think the fact that we're seeing such a big spike in RSV and flu right now suggests there's a lot more folks that are vulnerable, and it's going to be hard and it's going to be worse.
Yeah, I actually have a couple of patients in the hospital right now with an older patient who has actually flu, and then a couple of younger patients who have RSV as well, too. So it's definitely affecting my patients, too. Well, and let's not forget about the third leg of our triple-demic here and COVID. I know at this point you mentioned pandemic fatigue, and a lot of people are just not testing at all or doing just home tests. How accurate is our current COVID data right now? I feel like the numbers are not really high right now in terms of what we're tracking, but we don't have nearly as robust a system for tracking COVID as we do, for example, influenza, which we've done for decades.
Yeah, I think our systems for tracking all these diseases are better. And that may mean the public gets more messages about where we're at. But the home tests, if somebody has a positive home test, we're not going to hear about it. So what that's going to affect is, for example, the percent positivity, which is a good guide to how much COVID circulating. And that's probably not as accurate anymore. But I think what is likely to stay accurate is COVID-associated hospitalizations and COVID-associated deaths. And if we pay more attention to those, I think we have a sense about where COVID's at. And my understanding is that the COVID-associated deaths are about 2,500 a week. And that's terrible, but that's not nearly as high as it was at the worst when we had about 25,000 deaths a week. So about tenfold higher. And then the hospitalizations, the COVID hospitalizations are kind of at a medium level. They're not at the super high levels, but they're not down at the rare levels that we can sort of let up our guard. So that's my understanding. I agree with you that the data is probably less accurate because of home testing, but
yeah. And I think part of my concern also is hospitalizations and death from COVID is sort of trailing indicators versus leading indicators. And so it's hard, once we already see those numbers rising, it means rates are already probably pretty robust in the community as well too. I think the other interesting thing we have to think about also is, for example, patients being admitted here in Fontana, they're all tested for COVID. Every single patient who's admitted, regardless of whether it's for, a UTI versus a knee replacement, they're all tested for COVID. And I've seen a lot of patients who test positive for COVID in the hospital, even though they are admitted for something entirely different and their COVID is minimally symptomatic or asymptomatic as well too. And so I think it'd be interesting to see those numbers shared differently, to see who's admitted because of COVID and who's admitted happenstance with COVID as well too.
Well, and a point, I totally agree. A point I made earlier, our data systems are better. There are some really good COVID disease surveillance systems, and they're able to tease apart hospitalized with COVID versus hospitalized for COVID,
right,
to some extent. And it depends on the place and the time of year, but it seems like often maybe 2/3 of patients are admitted for COVID, and there might be a third that are admitted with COVID, but they're not sick from COVID. Right. So I agree with you totally, but I think, and I agree that those are sort of trailing indicators, meaning they come late and the cat's out of the bag. There's a lot of COVID in your community already. So we need to be cautious and careful, but I think we'll still have a sense about how much bad stuff COVID's causing. Yep.
Yeah. That makes perfect sense. Well, let's turn to kind of prevention. So there's no vaccine yet for RSV, although maybe you can share some insight there. But we have very effective vaccines against both flu and COVID. What are you hearing amongst your patients and your other colleagues? What can physicians do to protect themselves and also educate their patients to protect themselves and their families as well, especially as the holidays roll around and we're much more likely to be together in close proximity to grandma, grandpa, newborns who may be high risk for some of these respiratory viruses?
Yeah, so maybe let's take that in three pieces, Alex, if that's okay. So for RSV, as a pediatrician, again, I've been seeing sick kids with RSV for my whole career. And now there's promising development for RSV vaccines. First time ever, really. And it's going to be pretty incredible. They're not going to be ready this winter, but maybe a year from now. And there's even a vaccine that if you give it to the moms while they're pregnant, it prevents severe RSV in their babies for the first 3 to 6 months. And I was kind of, to be honest, astounded by that.
That's amazing.
Story coming there, but promising.
Okay.
As far as stay tuned. As far as flu goes, as we know, flu vaccines are kind of disappointing in some ways. They're less effective than we wish they were. I totally acknowledge that. I think we all should acknowledge that, but we should remember we're trying to prevent hospitalizations. We're trying to prevent somebody from spending their Thanksgiving in the ICU. And flu vaccination is more effective at preventing the most serious stuff. And so I think we strongly encourage everybody to get their flu vaccination. I'm vaccinated, and it's because I don't want to spend, Thanksgiving in the ICU either. And I think we need to acknowledge that folks are tired of these messages, and we need to, but I think if we keep the message as direct and clear as clear as we can, and say, we think the flu is going to be bad this year, and we think that there's ways to prevent it, including protecting your family and protecting vulnerable members of your family. And so we continue to recommend flu vaccination, even though we recognize that it doesn't prevent all flu. And then when we get to COVID, couple points I'd make there. One is death from COVID's largely vaccine preventable. Okay. And I'll say that again, death from COVID's largely vaccine preventable. And so even if even if vaccination is not preventing all COVID, it is preventing the most serious outcomes there. And that data is pretty darn strong. Your chance of dying from COVID is a lot higher if you're unvaccinated. And when I can give you numbers, often it's sort of 10 times higher, depends on your age group and some other stuff. So we'd encourage COVID vaccination, and then that gets us into the whole bivalent discussion. So if you want me to jump in there, let me know.
You read my mind. So tell us about the bivalent vaccines, which have been now authorized for a couple months. I think uptake's been pretty low, around 10% or so of the population, which is probably not enough to provide a great degree of community or immunity protection. So tell us more about the COVID bivalent vaccines and what your personal and professional recommendations are.
Yep, you bet. So bivalent means the same as updated. And what it's got 50% of the original strain and then 50% of Omicron. And so if you think about it, do you want something today that protects you from the threats that were happening 2 years ago? And I'd say, nah, not so much. Yeah, I want something that protects me against what's out there right now. That's what the Omicron part gives you. But if you think about it as, I don't know if this is the best example, but a map, and sort of the original strains over here and Omicron's over here, what we think is that it actually gives you protection against new variants that might show up in between those two spaces. I realize the map analogy is maybe not perfect, but the goal is not just to protect against Omicron, which is circulating now, but it might also give us protection against anything that comes along that is a little related to original and a little related to Omicron. That's the goal. I think it does. There's good evidence that it gives you broader immunity, but people have booster fatigue. I mean, I just think they do. And what I mean by that is they're tired of getting the message, oh, you need another booster, you need another booster. And in fact, it might be counterproductive because then it convinces them that it wasn't giving them that much protection all along. Mm-hmm. And that's really understandable. But I would try to steer the conversation in a different way. And again, sort of say, we're in a good position to have vaccines that protect against what's out there now and what may be out there in the future. And again, our goal is to prevent you from ending up in the ICU with COVID. And these vaccines appear to be highly effective at doing that. There just was some data released in the last couple of days that show that your antibodies against Omicron are a lot higher with this new vaccine booster. Some of that data was available a little while ago, but there's some new data that just came out, again, that the antibodies are great. And so that should provide us with some really good protection against what's out there now. But I get it, and everybody's tired of hearing about boosters. But I would still say anybody 5 years of age and older, everybody's eligible for a bivalent. Okay, everybody can get it. There are some exceptions, like if you just got a shot in the last 8 weeks, a COVID shot in the last 8 weeks, if you had a severe allergic reaction to COVID vaccine in the last last 8 weeks, sorry. If you've ever had a serious allergic reaction, then you don't get a booster. But so there are some exceptions, but generally speaking, everybody can get a booster. So, and everybody should, because again, we don't want to end up in the ICU, spend our holidays in the ICU with COVID.
Yeah, I got
or our
COVID.
Family members. Yeah,
right, exactly. I got my COVID booster. I got my 3 kids, 6, 10, and 12. Their COVID boosters as well too, in anticipation of some traveling and getting together with families this holidays as well too. So I think that's really important. When I'm talking to patients about the COVID booster, I always recommend it. I can see their eyes kind of start to roll a little bit. I always like using the car analogy. When you're driving in the car, you wear your seatbelt, you have an airbag, you drive the speed limit, you're not texting on your cell phone. All those things can add up to help reduce your risk of having a car accident as well. No one thing is going to fix it entirely, but all those things together are part of the way to keep yourself protected as well too. And so that's the way that I always sort of frame it with all my patients, is that, yeah, the bivalent booster is not the end all and be all, but it's an important piece of the puzzle to keep yourself protected as well.
Yeah, I totally agree. And what I'm finding is that people are judging their own individual risk. And by that, I mean, people are thinking, I've got a trip coming up. I've got a bunch of family coming. I've got grandparents who are going to be here and they're in their 80s. And that really does motivate them in a way that just talking about sort of broad public health messages, everybody in the country should get an updated vaccine doesn't really hit home quite as much. So I think when we talk from our hearts and just say, look, my kids are vaccinated, I'm vaccinated, that helps, because it shows them that we think it's an important thing to do to protect our health. So, but I also think we need to sort of acknowledge those things like pandemic fatigue and booster fatigue. But I do feel like it helps to have the kind of messaging that you're talking about, for sure.
Yeah. So there's a question here in the chat, which I was actually just sort of thinking about. So they must have read my mind. Are COVID boosters going to be like the flu vaccine, where we'll have to get one every single year, similar to the flu shot? I know there's been some messaging in the last couple of months that we'll have to get annual COVID vaccines, or the recommendation. I'm not sure the data is quite there yet, but I'd love to hear your thoughts on whether we're going to be getting a fluvid vaccine next fall with both COVID and flu together.
Yeah. So I wish I knew, and I don't know. I'm sorry. I think first of all, COVID's here to stay, and maybe that's just sort of stating the obvious. And, I think immunity wanes. So I think the likelihood is that we're getting an annual booster. Our flu vaccination rates every fall aren't where they'd like us to be, but it's something we can all plan around, and we can work towards having a consistent message there. And so I'm hoping that that's going to be the case, but I think it's too early for us to tell for sure. I will mention a couple things. One thing we haven't talked about is safety. Okay. And more and more data is accumulating about the high degree of safety of COVID vaccines. I feel really comfortable recommending it across the board: young kids, old kids, pregnant women, adults with chronic conditions. I just do. More and more data is accumulating. There are rare things that happen. We've talked about myocarditis before, which is heart inflammation. It does happen. It's pretty rare. And when it happens, those young adults appear to recover fully. Okay. And COVID disease itself is a lot worse on your heart. So we're getting a lot of data about that. But I think it's understandable that folks have questions about safety. And then another piece I'll add is people ask, can I get my COVID vaccine at the same time as my flu vaccine? There's also good data now that shows as safe, as effective to do those together. In terms of those sort of annoying side effects that you get the next day, they might be a tiny bit more. You might get a little more of that muscle fatigue, or, muscle aches. You might get a little bit more of that sore arm, but it's really just kind of pretty marginal. It's a little bit more, and it kind of makes sense. You have some of that with flu vaccine, you have some of that with COVID vaccine, you put them together, you might get a little bit more of that, but it's not like you're going to have to take the day off from work kind of a thing for most people. So I think, again, there's good data about the safety of doing that. There's good data about the effectiveness of doing that. So certainly if you're there, if you want to split them up, great, but just make sure you have a plan to do so that you don't miss whatever that second one was going to be. But it's perfectly fine to do it together too, same day.
Yeah. So great. Another great question here in the chat. So maybe especially for younger children, when they have these symptoms of RSV or flu or COVID, which can sort of be kind of overlap, especially at the beginning, what is your best approach to testing? Do you test for all three? What is the best way to help parents decide when their kid should get tested and what they should test for?
Right. So that's a great question. That's a complicated one. And I try to work with families and see where they're at, see whether they have got a daycare requirement for a certain amount of testing. I think most important is a couple things. For parents, trust your gut. If your kid is sick and you're worried about how sick he or she is, bring them in. Okay. Should be seen. And if you're not sure, talk to the nurse advice line where you get your care. But trust your gut. And if you're worried, we're worried. Okay. Second thing is, most often testing isn't needed. Most often. Okay. And the reason is because it doesn't change what we do as family medicine physicians or as pediatricians. But there are some exceptions to that. So I don't want folks to get the message, don't ever test. There are some exceptions to that. If it's somebody who's going into the hospital, it might make sense to test. If it's a young child who we might treat with an anti-flu medication, then it might make sense to test. Although the risk of that is that you don't want to wait for the test result to come back. So if it's a kiddo under the age of 2 who you really strongly think has flu, we recommend you just go ahead and treat them with an antiviral. If the testing is going to make you make plans about whether to see the grandparents or not, and it's really somebody vulnerable, I think that's reasonable to test, because you want to do that. But at the same time, any kid who's got a fever and a real snotty nose and coughing and stuff, that kid's infectious or contagious with whatever they have. So I think you got to use your common sense and judgment there for sure. But usually we don't need to test unless there's those exceptions, or if somebody's immune compromised, like I said. So going in the hospital really young, immune compromised, those kind of things. Something we haven't talked about, I don't think ever before, Alex, is sort of what about the 3% of the US population that's immune compromised?
Yeah.
And, they're at greater risk, and they've been super careful through the pandemic because they're worried and they know what would happen if they got any of these diseases, but COVID, I'd mention in particular. So, we need to recognize that we've got these recommendations for the general population, but for somebody who's immune compromised, there are extra steps that they can and should take. There are things like EvuShield that are available for them. And it's not going to be a perfect cocoon or form of protection, but they can get some significant protection, and should, because their risk of getting really sick if they get infected is a lot higher.
Yeah, that makes perfect sense. This is fantastic. We could go on all day, but we try to keep these pretty short and high yield. So last question, what makes you most proud to be a Permanente physician?
I love it when you ask me that, because there's just a ton of stuff. There's so many things. I don't know if this is what I mentioned last time, but if so, bear with me, and because I want to mention it again. So at Kaiser, we participate in the Vaccine Safety Data Link, and that's one of the most advanced systems for monitoring vaccine safety, arguably in the world, for sure in the country, but arguably in the world. Kaiser also participates in vaccine effectiveness studies, which are kind of the real world studies, not in the laboratory or the phase 3. Yep. They're the what happens in the real world kind of studies. And so what makes me proud is that Kaiser contributes to medical knowledge that helps the world know how effective are these vaccines and how safe are these vaccines. That makes me very proud.
Yeah, that's amazing. So, well, thank you, Matt, for joining us. I really appreciate you taking the time.
Yeah, you bet. Thanks. Really appreciate it.